Okay, now I will present my presentation. Can you see the presentation, Fuja?
Yeah, I can see.
Okay, today's our lecture is very interesting lecture because it's very near to our subject, near our dentist, about the dentistry. So today our lecture subject is applying the epidemiology in public health practice and oral health surveillance.
Okay.
We described at our delivered lectures as assessment. Assessment is one of the three core public health functions, as you know, and together with policy development and assurance, so this is the three core public health functions, yeah. And in public health dentistry, one key element of assessment is the ongoing monitoring of a community's oral health status. The process of ongoing monitoring is more commonly known as surveillance. So, defined by the CDC, you know the definition, it's a Centers for Disease Control and Prevention, as the ongoing systematic collection, analysis, and interpretation of outcome specific data for use in the planning, implementation, and evaluation of public health practice. The information obtained through public health surveillance is used to assess public health status, define public health priorities, evaluate programs, and conduct research. Simply, surveillance information tells you where the problems are, whom they affect, and where programmatic and prevention activities should be directed. So, for an oral health surveillance system to be comparable between local, state, and national jurisdictions, and it must be based on uniform data standards and measurements. Today, we present the standard methods for measuring dental caries, periodontal disease, dental fluorosis, treatment urgency, and tooth loss, and also the other oral conditions in populations. The purpose of these measures is to describe the oral health of the community rather than the individual. For this reason, the methods outlined today's lecture are appropriate for public health practice, but may have little value in a clinical setting with an individual patient. In addition, certain oral health measures or indices are useful in a clinical setting, but are of little use in a community setting because they are too time consuming or have low reliability. Description of indices for individual patients, for example, plaque control record and interdental bleeding index, can be found in most clinical dental hygiene textbooks. National and state level oral health surveillance data are maintained in the National Oral Health Surveillance System, and it's a National Oral Health Surveillance System is a collaborative effort between the Association of State and Territorial Dental Directors and the CDC. Currently, there are 8 oral health indicators included in National Oral Health Surveillance System. It's a caries experience, untreated caries, dental sealants, tooth loss, annual dental visit, teeth cleaning, fluoridation, and oral and pharyngeal cancer. Most measures presented today are referred to as an index. An index is a graduated numeric scale that has upper and lower limits with scores on the scale corresponding to specific criterion for individuals or populations. In general, the higher the index score, the more disease will be present. For an index to be useful in public health practice, it must be both valid and reliable, also referred to as validity and reliability. To be valid, it must measure what it is intended to measure. For this reason, levels of the index should correspond with the stages of the disease under study. For a gingivitis index to be valid, it must measure the prevalence and severity of gingivitis rather than the prevalence and severity of some other condition. Reliability refers to the ability of an index to consistently measure the same level of disease at different times by either the same or different examiners under various conditions. Reliability can also be thought of as repeatability, reproducibility, and consistency. For an index to be considered reliable, two different examiners should be able to obtain the same score for the same person being examined. This is referred to as inter-examiner reliability, and in addition, one examiner should be able to obtain the same score if the same person is examined twice. Referred to as intra-examiner reliability. All of the indices presented today's lecture and are considered valid. They are also considered to be reliable if the examiners are trained and calibrated. Training and calibration is an essential component of any community-based oral health needs assessment. The purpose of training examiners is to ensure that each person involved in the assessment is making consistent clinical judgments and to ensure uniform interpretation, understanding, and application of the codes and criteria for the various indices used. To better understand the concept of reliability, consider each of your clinical dental hygiene instructors. Most hygiene students would agree that some instructors view a clinical case differently from other instructors. To make each instructor grade a case in a similar manner, the instructors must have extensive training and regular calibration. In this case, instructor calibration would consist of each instructor independently examining several patients, and the results would then be compared and adjustments made in how each instructor grades or scores a case so that all instructors agree on the final assessment. The calibration process can be quite lengthy and challenging to achieve the reliability desired. The surveillance versus clinical diagnosis. Also, dental public health surveillance activities often include an open mouth examination. The examination process for surveillance and research differs significantly from a comprehensive clinical examination for the purpose of diagnosis and treatment planning. In most cases, a surveillance activity uses an abbreviated open mouth examination, often referred to as a screening. Mhm. As a screening. A screening examination rarely includes radiographs and often looks at just one disease process, such as dental caries in children or periodontal disease in adults. In addition, most screenings don't include the use of a dental explorer or periodontal probe, and many only use a tongue blade and flashlight. For this reason, it is not appropriate to use screening examinations for the purpose of diagnosis or treatment planning. If a potential problem is identified during a screening, the individual should be referred to a dentist for a comprehensive examination. It is also important to understand that surveillance activities can collect different levels of information at varying costs. For this reason, program budgets must be considered when deciding what type of information to collect. The more information collected, the more it will cost in terms of time for data collection, data entry, and data analysis. Now, how we can the measuring dental caries? Dental caries is an infectious disease process that results in loss of tooth minerals, demineralization, on the outer surface of the tooth. If not controlled or remineralized at an early stage, caries can progress through the enamel, into the dentine, and eventually into the pulp. Dental caries occurs in both the primary and permanent dentitions and on both the coronal and root surfaces. Because of differences in the measurement of caries on coronal versus root surfaces, the major measurement of each surface type will be addressed separately. How we can measure the coronal caries? The traditional methods for measuring caries experience, both present and passed on the coronal surface of the permanent dentition, is the decay, missing, and field index, DMF. The DMF index, which usually excluded the four third molars, counts either the number of teeth with a history of caries. So DMFT is the decay, missing, and failed teeth, or the number of surfaces with a history of caries. DMFC, its definition is decayed, missing, and filled surfaces. After systematic evaluation using a mouse mirror and good light source, each tooth or surface is scored as decayed, missing, or filled using the following diagnostic criteria. Decayed, loss of tooth structure at the enamel surface, missing is the tooth loss due to caries, and filled is the restorative treatment resulting from caries. Note that because teeth lost as a result of orthodontic structural injury are missing for reasons other than caries, they are not counted as missing in the DMF index. An individual's DMFT score will be a whole number ranging from 0 to 28 if third molars are excluded. An individual's DMFS score will also be a whole number ranging from 0 to 128. When calculating this score, the 16 posterior teeth are considered to have 5 surfaces and the 12 anterior teeth to have 4 surfaces. The mean DMF score for a community is a total score for all individuals divided by the number of people in the community. Also, the decade missing and field index was designed to assess the coronal aspect of the permanent dentition. It has been modified for use in the primary dentition. The standard caries indices currently used in the primary dentition are the DF index, so decade field index, and the DMF index, so decade, missed, and field index. The DF index counts either the number of decade and field primary teeth or the number of decade and field primary surfaces. Because it is difficult to determine whether a primary tooth has been lost because of caries or natural exfoliation, missing teeth are often not included in this index. The DF index is generally used in children who are beginning to exfoliate their primary teeth, and occasionally you may see reference to the decade indicated for extraction and field index for caries in the primary dentition. The DEF index will always have the same score as the DF index because the DF index combines decade and indicated for extraction teeth into the same category. Most oral health surveillance programs will report a DFT or DFS score rather than a DFT or DFS score. The DMF index can be used in children who have not yet reached the age of natural exfoliation to assess the number of teeth or surfaces, later decade missing because of dental caries or field. The original description of this index, published in 1944, and describes the index as only being used in children ages 7 to 12 years. And today, the DMFT and DMFS index is generally used in preschool children, and the DFT and DFS index is used in children with mixed dentition. If you see reference to the only being used in older children, please note that this is no longer the case for oral health surveillance systems. The benefit of using a DMF index to measure dental caries is that it provides a measure of disease severity in addition to an estimate of disease prevalence. However, a dental public health program is usually only interested in prevalence rather than severity of dental caries. The appropriate tool for measuring dental caries prevalence in a community is the basic screening survey. Originally developed by the association ASTDD in 1999, the basic screening survey gathers information at a level consistent with monitoring the national health objectives found in the USA Public Health Services Healthy People document. And in other words, the BSS gathers information on a per person basis rather than on a per tooth or per tooth surface basis. Each person screened and classified in a dichotomous manner. It's a yes or no as to whether or not they have treated decay or untreated dental caries. The oral health status for a community or population is then presented as a percentage of the population that has caries experience and untreated decay. For example, a recent statewide survey of third-grade children in Connecticut found that 41% had caries experienced and 18% had untreated decay. Also, the DMF index differences differentiates between permanent and primary teeth. And the BSS model does not differentiate between the two. For example, if a child is classified as having caries experience, the caries experience may be in their primary and/or permanent dentition. And the BSS model does have one indicator for the primary dentition only, early childhood caries. This indicator is designed for preschool children, and the 6 maxillary anterior teeth, it's an and yes, you can see also the use of upper and lowercase letters for dental caries indices. It's the uppercase letters are used when caries indices refer to the permanent dentition, and lowercase letters are used when caries indices refer to the primary dentition. Yeah. This is the 6 maxillary anterior teeth. It's the center incisors, lateral incisors, and canines are examined to determine if the child has untreated decay, a filling, or a tooth missing because of caries. If any of the 6 maxillary anterior teeth have caries experience, the child is classified as having early childhood caries. So, root caries, a classification system similar to DFT and DFS index, can be used to measure the prevalence and extent of root caries on exposed root surfaces. Each root or root surface is classified as being either decayed or filled. Unlike the indices for coronal caries, missing roots are not included in the total score for an individual. And the problem with counting the number of decayed and or filled roots is that the individual's score does not take into account the number of roots or root surfaces at risk. And the root caries index, RCI, is a measure of root caries that includes the number of exposed root surfaces as the denominator. The RCI is calculated by adding the number of decayed and filled root surfaces and then dividing the number by the number of root surfaces with gingival recession. And the resulting number is then presented as a percentage, which means that it is multiplied by 100. If a person has an RCI of 12%, it means that of their teeth with gingival recession, it means that of their teeth with gingival recession, 12% of the root surfaces are either decayed or filled. How we can measure the periodontal status? Measuring the periodontal status. The Community Periodontal Index is a quick, easy method for assessing and describing the overall periodontal status of a community. The CPI, which is promoted by the World Health Organization and used throughout the world, evaluates 3 indicators of periodontal status: gingival bleeding, calculus, and periodontal pockets. Gingival bleeding, calculus, and periodontal pockets. It does not evaluate clinical loss of attachment. Until recently, the CPI was known as the Community Periodontal Index of Treatment Needs. And changing patterns of periodontal treatment, however, have invalidated the treatment needs portion of the original index. For this reason, the index is now used to evaluate periodontal status rather than periodontal treatment needs. The CPI uses a specially designed lightweight probe with a 0.5 mm ball tip and black bands between 3.5 and 5.5 mm and rings of 8.5 and 11.5 mm from the ball tip. In adults ages 20 years and older, 10 index teeth are evaluated. 2, 3, 8, 14, 15, 18, 19, 24, 13, and 31. In those younger than age 12, only 6 index teeth are examined. It is 3, 8, 14, 19, 24, and 30. After gently probing the index teeth, each tooth is scored according to the codes outlined. So CPI codes, you can see that it is a CPI codes and criteria. 0 is healthy. 1 means bleeding observed directly or by using a mouse mirror after probing. Uh, Second is a calculus detected during probing, but all of the black band on the probe visible. Then pocket 4-5 millimeter. It's a gingival margin within the black band on the probe. And pocket 6 millimeter or more black band on probe not visible. Excluded segment less than 2 teeth present and not recorded. In the early 1990s, a modified version of this periodontal screening and reporting was introduced in the United States. And the PSR is designed for use with individual patients in a clinical setting rather than for community periodontal status assessment. Another approach to evaluate the periodontal status of a community is to separately measure each individual aspect of periodontal disease. Using this approach, each of the following aspects of periodontal health would be measured: gingival bleeding, recession or loss of periodontal attachment, pocket depth, and plaque and calculus as contributing disease factors. Because collecting each aspect of periodontal health is time-consuming and expensive, this approach is rarely used by public health programs. This approach is measuring periodontal health in a community-based population is usually limited to research projects. One of the most commonly used indices for assessing gingival bleeding is the gingival index, GI. With the GI, a periodontal probe is inserted about 2 to 3 millimeters into the sulcus and gently swept around the tooth, rather than being walked around the tooth. And the mesial, distal, buccal, and lingual surfaces of each tooth are then given a score of 0 to 3 based on the criteria we described. It's so I will show you. It's a GI codes and criteria. 0 means normal gingiva. Then mild inflammation, slight edema, and change in color. No bleeding on probing. It's very important. Moderate inflammation. It's redness and edema, bleeding on probing. And severe inflammation, marked redness and edema, ulceration, tendency to spontaneous bleeding. There are no specific indices designed to measure loss of periodontal attachment or pocket depth. The tools used to measure this aspect of periodontal health is community-based survey are the same as those used to measure periodontal status in clinical practice. However, the World Health Organization suggests the use of an ordinal scale for recording loss of periodontal attachment similar to the ordinal scale used for the CPI. And you can see the scoring loss of attachment. It's LOA, Coating criteria. 0 means that the pocket is from 0 to 3 millimeter, then 4, 5 millimeter, 6, 8, 9, 11, 12 millimeter or more, excluded sextant and not recorded. List the coding criteria recommended by the World Health Organization for recording loss of attachment in community-based surveys. Two indices have commonly been used to measure the presence of plaque and calculus. The first is a simplified oral hygiene index, and the second is the plaque index. The oral hygiene index evaluates both supergingival and subgingival plaque and calculus on 6 teeth. It's the 3rd, 11, 14, 19, 24, and 15. Also commonly used in the past, the oral hygiene index is becoming obsolete as periodontal research focuses more on subgingival rather than supragingival plaque and calculus as periodontitis risk factors. And the PI was initially designed for use with the GI described earlier, as with the GI and PI score the mesial, distal, buccal, and lingual surface of each tooth on a scale from 0 to 3, based on the thickness of plaque at the gingival margin. The scoring criteria for the PI are shown at our presentation. It's no plaque. You can see it's no plaque, the first one. A film of plaque adhering to the free gingival margin and adjacent area of the tooth. The plaque may be recognized only by running a probe across the tooth surface. The second is a moderate accumulation of soft deposits within the gingival pockets that can be seen with the naked eye or on the tooth and gingival margin, and abundance of soft matter with the gingival pocket and or on the tooth and gingival margin. Completing a full mouth periodontal status assessment on a group of individuals can be time-consuming and cost-prohibitive for many research projects and public health programs. For this reason, several methods have been developed that evaluate only a subset of teeth in the mouth. One such method was developed in 1950s by Dr. Sugar and Ranford. Using this method, periodontal assessments are only completed on 6 teeth known as the Ramfjord teeth or the Ramfjord index teeth. These 6 teeth include the maxillary right first molar, left central incisor, left first premolar, mandibular left first molar, right central incisor, and right first premolar. And the partial mouse method used in the National Health and Nutrition Examination Survey from 2001 to 2004 evaluated 2 randomly selected quadrants, one maxillary and one mandibular. For each tooth in these randomly selected quadrants, measures were taken in only 3 sites: the mesiobuccal, buccal, and distal. Although completing partial mouse periodontal assessments are not appropriate for clinical settings because of the localized nature of periodontal disease, and they do provide valuable and appropriate information for oral health surveillance and the monitoring of disease trends in populations. When we're reading the older dental literature regarding the prevalence and severity of periodontal disease, we can see references to periodontal indices not included in this section. Because our understanding of periodontal disease has changed significantly in the past 20 years. Many previously used indices for measuring periodontal status are now obsolete. And three such obsolete indices are the periodontal index, PI, periodontal disease index, PDI, and the papillary marginal attached PMI index, although they may still be included in some dental hygiene textbooks. Now, how we can measure the dental fluorosis? Measuring the dental fluorosis during tooth development, ingested fluoride becomes incorporated in the enamel structure of the teeth. If excessive amounts of fluoride are ingested, dental fluorosis can develop. Dental fluorosis is defined as hypomineralization of the dental enamel caused by excessive ingestion of fluoride during tooth development. The appearance of dental fluorosis varies depending on the quantity and timing of fluoride ingestion. It can range from barely noticeable to noticeable brown staining and pitting of the animal. Several indices measure the prevalence and severity of dental fluorosis. The most common are Dean's fluorosis index and the tooth surface index of fluorosis. With Dean's fluorosis index, the score for an individual is made on the basis of the two most affected teeth. If the two teeth are not equally affected, the score for the less affected of the two teeth is recorded. Also, the Dean's fluorosis index only records the score for the two most affected teeth. And the tooth surface index of fluorosis gives a score for each tooth surface in the mouth, and the TSIF provides more comprehensive information on the amount and distribution of dental fluorosis for an individual. However, it is time-consuming, and the World Health Organization recommends that community service use Dean's fluorosis index, and the cause and criteria for Dean's fluorosis index and the tooth surface index of fluorosis. It's listed here, and we can read this chapter. Now, measuring the treatment urgency. Many public health programs are not necessarily interested in the level of oral disease, but they may be interested in the proportion of the population that is in need of various levels of dental care. Two different organizations have developed criteria for quantifying treatment urgency. The first is American Dental Association, which developed a four-level treatment urgency scale in the 1950s, and the second organization is the ASTDD, which developed a three-level treatment urgency scale in 1999. Most public health programs now use the ASTDD scale because of its improved reliability. And this one is that's the treatment urgency scale. You can see ASTDD treatment urgency scale. Is there are no obvious problems? Routine dental care is recommended at next regular checkup. Early dental care is recommended within several weeks. Caries without accompanying signs or symptoms individuals with spontaneous bleeding of gums, uh, suspicious white or red soft tissue area, or ill-fitting dentures. Urgent emergency care is recommended within 24 hours, and signs or symptoms include pain, infection, swelling, or soft tissue ulceration of more than 2 weeks duration, determined by questioning. And American Dental Association treatment urgency scales apparently requires to know dental treatment, requires treatment but not of an urgent nature, requires early treatment, and requires immediate dental treatment. Yes. Now measuring the tooth loss. Tooth loss is one of the few oral health conditions that can be reliably measured through an open mouth examination or self-administered questionnaire. Administered, questionnaire. When measuring tooth loss, however, a distinction must be made between loss of certain permanent teeth and total tooth loss. Total tooth loss or loss of all natural teeth is also referred to as edentulosum. A state-based ongoing data collection program designed to measure behavioral risk factors in USA adults and the behavioral risk factor surveillance system monitors tooth loss through a telephone survey. Each month, states select a random sample of adults for a telephone interview, and this selection process results in a representative sample for each state so that statistical inferences can be made from the collected information. During these years, all states asked a core set of oral health questions to obtain information on time since last dental visit, time since last tooth cleaning, and tooth loss. The following question was used to determine the prevalence and severity of tooth loss in USA adults. And question is, how many of your permanent teeth have been removed because of tooth decay or gum disease? Include teeth loss to infection, but don't include teeth loss for other reasons, such as injury or orthodontics. And response, none, 5 or fewer, 6 or more, but not all and all. Uh, and what about measuring oral and pharyngeal cancer? As with other cancers, oral and pharyngeal cancer is usually expressed as a rate of proportion. For example, the 2005 age-adjusted incidence rate for cancers of the oral cavity and pharynx was 14.7 per 100,000 population for white males and 15.1 per 100,000 population for Black or African Americans males. There are two primary methods for measuring mortality and morbidity from oral and pharyngeal cancer, and mortality rates and incidence rates. Mortality rates from cancers of the oral cavity and pharynx are generated by the CDC's National Center for Health Statistics, and which obtains data from death certificates collected through the nationwide statistics system. Mortality data, together with other vital statistics data, can be obtained from the NCHS website. You can read there. And information for the calculation of cancer incidence rates is obtained through a network of local and state cancer registries that receives the report of new cancer cases from physicians and hospitals. 18 such population-based cancer registries, uh, American Indians in Arizona, and so on, so on, uh, participate in the surveillance epidemiology and end result program, which is conducted by the National Institutes of Health, National Cancer Institute, and CEER is the primary source of all cancer incidence data in the United States. And it means that CEER means it's a surveillance epidemiology and results. Now, how to complete a community-based oral health needs assessment. Also, we describe the basic information on dental indices and other measures of oral health, and it doesn't provide detailed information on how to complete an oral health survey. Planning and implementing a comprehensive community-level oral health survey is an arduous task that is beyond the scope of this text. There are, however, three guides that give detailed information on how to complete an oral health assessment. The first is assessing oral health needs, an ASTDD seven-step model we developed and produced. It was produced by ASTDD, and these seven-step models we described at our delivered lectures and gives detailed information on how to conduct and comprehensive needs assessment, ranging from the evaluation of existing data to the collection of new data. Two other resources provide detailed information on how to implement an open mouth survey. They are oral health surveys, basic models published by a World Health Organization, and basic screening service, an approach to monitoring community oral health published by the ASTDD. Both references are extremely useful, and however, basic screening service, an approach to monitoring the community oral health provide the most practical information for monitoring the healthy people oral health objectives, and basic screening service, an approach to monitoring community oral health is available for downloading from the ASTDD website. You can list it in the resources section. And today we introduce the concept of oral health surveillance and describe methods commonly used to measure the prevalence of dental caries, periodontal disease, and dental fluorisis, tooth loss, and treatment urgency in a community setting. Using these methods, together with the needs assessment information presented in our earlier lectures, and you will be able to evaluate the oral health status of the community that you serve. And today, after studying this chapter and this lecture and this presentation, you completing the study question and exam activities, you must discuss the measures that can be used to assess the oral health status of a community, compare and contrast the clinical measures used in oral health surveillance, and you can describe the basic steps necessary to complete an oral health needs assessment. So, thank you, my dear students, for your attention. And we will meet you maybe in the next week. I will share you this presentation. Okay. Pooja, you have some question?
No, I just want to get that presentation if you could send me.
Yes, I will send it to Salome and she will share it for you. Don't
Okay.
worry about
All
it.
right.
Okay.
Thank
Bye,
you.
my
Thank you
dear.
so much.
Thank you, my dear. Bye.
Bye.